Hello everyone, I am Dr. Anupam here and today we will discuss about pulmonary embolism. We will cover this pulmonary embolism chapter in two classes. In the first class we will discuss about the diagnosis. In the second class we will discuss about the management protocol. So first let's discuss about pulmonary embolism diagnosis. Now remember, for a matter of fact, the pulmonary embolism is an extension of a DVT or a deep vein thrombosis. So let us see how it happens. So here we have a pictorial diagram where you have the right side of the heart, the right ventricle, the right atrium, the pulmonary artery is coming out of the right ventricle and divides into right and left pulmonary artery. The right pulmonary artery drains into the right lung, and we have SBC and IVC which drains the right atrium, right? So there is this formation of a DVT. It can form in the upper limb also, in the lower limb also. The most common is proximal DVT in the lower limbs. So this is the DVT. So how the DVT is formed? The DVT is formed because of three factors, right? So what are the three factors? Number one is stasis. Number two, endothelial injury. Number three is hypercoagulability, right? So you may remember these three are part of a very popular triad called the Workhorse triad. What is called? It's called Workhorse triad. So anything that disrupts the Workhorse triad can predispose the patient to DVT. For example, a patient who is bedridden, a trauma patient, a orthopedic post-operative patient, or endothelial injury, patient who is smoking, or a patient who have an indwelling central line catheter, or patient who are hypercoagulable, who are receiving estrogen therapy or other forms of steroid, or patient is a cancer patient or having any other pathology which can produce hypercoagulability, right? So this can produce the DVT. So once the DVT is formed, what will happen? Clinically, what will happen? There will be swelling of leg and tenderness, pain, right? So this can happen, right? The patient can present with these symptoms only. So once the DVT is formed, it has all the propensity to travel to the right atrium, to the right ventricle, and then it can lodge in the pulmonary artery main or in the subsegmental or segmental branches, right? Now what happens after that? Let us discuss. If you see, if the pulmonary artery has been lost by a thrombus or in the segmental or subsegmental region, what will happen? There are two components. One is retrograde to the thrombus, one is anterograde to the thrombus. Now the symptoms and signs will be produced depending upon how the different systems are involved. So let us first discuss about what happens retrograde. Retrograde means behind the thrombus, right? So if you see the thrombus is directly on the way of right ventricle. So what will happen? There will be acute pressure overload. And whenever there is acute pressure overload, the RV react to with dilation. So there will be RV dilation that will lead to RV failure, right? Third, because of the thrombus, there will be widespread inflammation. That inflammation will cause increase in pulmonary vascular resistance because of hypoxic and platelet-derived growth factor mediated vasoconstriction. And that increase fever in terms create a pressure on the right ventricle, cause right ventricle failure, right? Because of RV failure, what will happen? The LV preload will decrease, right? And that will lead to decrease in cardiac output, which can be compensated by increased heart rate, right? Plus there will be syncope or pre-syncope. Syncope and pre-syncope means there is exhaustion of hemodynamic reserve. So patient is in impending cardiorespiratory failure. So in the end patient will become hemodynamically unstable, right? Now what will happen? Interrogate. Now number 2 is what will happen? Interrogate. Now you can see the retrograde phenomenon are mostly related to the circulation part of the body. So circulatory failure will be retrograde phenomenon, and anterograde there will be mainly related to gas exchange. Now what will happen here? First, because of the thrombus there will be VQ mismatch. There will be airflow, but there will be no perfusion. So there will be VQ mismatch, which can cause hypoxemia, right? Second will be because of widespread inflammation. There will be capillary leak. It can cause non-cardiogenic pulmonary edema, right? And which can cause hypoxemia. Number 3 will be due to pressure overload, there can be reopening of foramen ovale, and it can aggravate hypoxemia. Now how the body will respond to the hypoxemia? By tachypnea, dyspnea and hypocapnia. Remember, what carbon dioxide is not perfusion limited. So carbon dioxide washout will be very good in pulmonary embolism, but there will be hypoxemia which will be compensated by tachypnea and dyspnea, right? And what else can happen? Because of distal thrombus, then can be hemorrhage, which can lead to hemoptysis, right? So it can be another presenting symptom. So if you see what happens in the retrograde or the circulatory part, there can be RV strain because of the thrombus, which is manifested in ECG by TUA inversion, S1Q3T3 pattern or RBBB, right? So these are the things that you can see in a patient who is presented to you with pulmonary embolism. Right? Now, because there is a DVT here and the body has activated the coagulation system and the fibrinolysis system, there will be increase in some fibrinolytic product in the blood, and that you can measure. So these are called the D dimers, right? So that will come when you diagnose a patient of pulmonary embolism, we'll see, but D dimers will be elevated in the blood. At the same time, because of RV pressure overload, we can have some echo findings. 2D echo. If you do 2D echo, in different view of echocardiography, you will find RV dilation, RV to LV ratio 1:1, septal flattening, Then we can have TAPSE of less than 15, which is representing of systolic RV failure, right? And we can see also streak of thrombus from RA to RV, right? This is the finding in the 2D echo we can see. Now let us see how using this method, using this diagram, how you can reach at a diagnosis of pulmonary embolism. Correct? So when a patient comes to you, patient will come to you with signs and symptoms, right? So you received a patient with signs and symptoms. And what are the signs and symptoms? Swelling of leg, tenderness, pain, RV strain in the ECG. Patient can be having syncope, tachycardia. Patient may be hemodynamically unstable, will be tachypneic, dyspneic, and if you do ABC, there will be hypocapnia. Patient can also present with hemoptysis, right? And then you examine the patient, you take the history, you find out there are predisposing factor. Right? So signs and symptom and predisposing factor. And what are the predisposing factor that we have discussed? That is the disturbances in the Burko's triad, stasis, endothelial injury, and hypercoagulability. Now, when both of these are present, we call this as suspected PE. Now, you have suspected PE. Now, it is not diagnosed. Right? Once you have suspected PE, the next step is you check their hemodynamic stability status. Right? So, if patient is hemodynamically unstable, so you have suspected PE and the patient is hemodynamically unstable. And what do you mean by hemodynamically unstable? Hemodynamically unstable means three things. First, decrease in blood pressure, that is SBP less than 90 for more than 15 minutes rather. Second, decrease in BP with fluid with pressures plus there is organ dysfunction. Number 3 is cardiac arrest. So these are the criteria for hemodynamic instability. So once one of the three criteria is present and the patient is hemodynamically unstable, it is at that time what you do a 2D echo. Because you do not have time to investigate the patient, what you can do best is to do 2D echo at the bedside. In the 2D echo, we can find out what we have discussed here: RV dilatation, RV to LV 1:1, septal flattening, TAPSE less than 15, or streak of thrombus from RV to RA to RV. Right. CT is also option here, if feasible or if possible. But in most of the case, it will not be the case, so it cannot be done because patient is hemodynamically unstable. So then, if 2D echo is suggestive, then you treat the patient, just end of the series. But if patient remains hemodynamically stable, it is at that time what we will do, we have enough time to investigate our patient. So the first, you go back to the history again. If in the history patient is presented to with swelling of leg, tenderness and pain in the calf muscles, then what will you do? You do a compression ultrasonography. So history suggestive of DVT. So you do a compression ultrasound. How it is done? It is done by 4-point method. You put the probe in both the inguinal region and the popliteal regions and find out filling defects. If it is so, if it is positive, then you start treatment, right? Because you had suspected PE, now you have confirmed evidence of DVT, so you start treating. If it is negative, what will happen? If it is negative and there is still high suspicion of PE, in that situation, what will you do? We'll follow the other protocol. Let us discuss that. So if there is patient is hemodynamically stable and there is no history of DVT and you have done a compressional ultrasonograph but it is negative, it is in that situation we have to, patient has to go through what I call as 2-filter system, right? So here we have two components. One is clinical predictive value and second is prediction criteria. So what are the prediction criteria we have? We have Wells criteria and we have Geneva's criteria. These you can find in the online calculators. However, what you have to do is, once you have two these clinical predictive values, either using 1 or 2, we have to divide the patient into two parts. One is low risk and another is high risk. And low risk also intermediate risk. So divide it into two parts, low risk, intermediate risk and high risk. In the low risk group, the next step will be do a D-dimer test. Now if the D-dimer test comes positive, then you will go ahead and do a ctpa. If D-dimer test is negative, then what will happen? You can safely rule out PE. However, if patient is high risk group, then you go ahead and directly do the ctpa. Don't do D-dimer test here. You go directly do ctpa test. And about D-dimer, D-dimer has high negative predictive value. And its normal value is 10 microgram into age per liter for age more than 50. Right? So, if a patient is high risk, because D-dimer has a negative predictive value high and a very low positive predictive value, so you do not do D-dimer test in patients who are having high risk of developing a PE. You go directly do ctpa. If ctpa is positive, then you treat. If ctpa is negative, rule out PE. And there are certain situations where you cannot do ctpa. Patient is having a renal failure, contrast allergy, or pregnant. In those situations, you cannot do a ctpa. So ctpa is contraindicated here. You cannot do ctpa. So what you will do instead? You will do instead a VQ scan. And VQ scan is highly sensitive. If you do a VQ scan, it is positive, then you treat the patient. If it is negative, then PE is ruled out. Right? Once you have diagnosed PE, now we have to treat the patient. Before treating the patient or while treating the patient, you have to answer another thing, that is called risk of early death and severity assessment. Right? How will you do this? This is done using, first is clinical criteria, which include signs and symptoms. Second will be comorbidities. Now we can include both of these and coin a simple criteria that is called sPESI, or Simplified Pulmonary Embolism Severity Index, right? Then you have third, you have to assess the RV function, and this can be done by two methods. One is imaging using 2D echo and the findings are mentioned, or you can do a CT, 2D echo and CT finding. And second is biomarkers. What are the biomarkers we have at our disposal? We have TROP-I, we have NT-proBNP, also can have lactate. So by using these three criteria, we can divide the patient into four groups. So first group will be high risk groups. Those patients who are hemodynamically unstable to present to it, they are the patient with high risk. They are gonna die in the hospital, most of them. Then we can divide the other patients into intermediate high groups. They are the patient who has a simplified PESI of more than 1 and they have both imaging and biomarkers positive. And then intermediate low group, those who have simplified PESI more than 1 and either of them is positive, either imaging is positive or biomarker is positive. Then we have the fourth group, that is low risk. They have a simplified PESI 0 and none of the above is positive, neither imaging nor biomarker is positive. So this is a very important tool to prognosticate your patient and family members, and this will also come handy when we will discuss the treatment protocol. So today in our class we have discussed, when a patient comes to you with signs and symptoms that is pertaining to DVT or PE, it is at that time we have to look out what are the exact signs and symptoms that we have discussed here. Patient can have a tachycardia, syncope, patient can be hemodynamically unstable, there can be RV strength pattern in the ECG, patient can have tachypnea, dyspnea. If you do a ABG, you will find there is hypocapnia, alkalosis, and patient can present with hemoptysis, signs and symptoms of DVT, swelling of left, pain and tenderness, right? So then you go to the history of the patient and find out what are the predisposing factors that is present in that patient. What are the predisposing factors? Anything that disrupts the work stride that we have discussed. Right? Now we have a patient which is called suspected PE. So suspected PE is equal to signs and symptoms plus predisposing factors. Right? So then whether the patient is hemodynamically stable or unstable. If the patient is hemodynamically unstable, it is at that time you go ahead and do an transthoracic echocardiography. And what are the findings we have discussed? You can have a RV dilatation, RV to LV 1:1, septal flattening, TAPSE, which is a marker of systolic RV function, maybe less than 15 millimeter, and you can see a streak of thrombus going from right atrium to right ventricle, right? If these findings are present, that means it is suggestive of PE. So you go ahead and treat the patient for PE. However, if the patient is hemodynamically stable and there is signs and symptoms of DVT in that patient from history, you go ahead and do a compression ultrasound. 4-point method, to inguinal to popliteal. And if you see a filling defect, that is diagnostic of DVT, and you immediately treat the patient for PE. However, if there is no history suggestive of DVT and compression ultrasonography is negative, patient is hemodynamically stable, then you put those patients in a filter method. two-step filter method. What are the two steps? We have clinical predictive value and prediction criteria. Using either of them, you have to divide your patient into low risk or high risk. Those patients who are in low or intermediate risk, they will go ahead and do a D-dimer test. If the D-dimer test is positive, they will be done a ctpa. If the ctpa is positive, you will have to treat for PE. However, because D-dimer is a very highly negative predictive value, if it is negative, it virtually rules out PE. However, those patients who have a high risk, they can go ahead and directly do a ctpa. If it is negative, it rules out PE. If it is positive, you have to treat for PE. There are certain patients in which you cannot do a ctpa. Young patient, pregnant, contractile general failure. In those situations, you have to do a VQ scan. If the VQ scan is positive, you have to treat for PE. If it is negative, it rules out PE. All those patients who has been diagnosed positive for PE, one more thing you have to do. You have to risk assess the patient and prognosticate. Severity assessment you have to do. And for that, we use 4 methods or 4 criteria. 1, clinical criteria. 2nd, comorbidities. You can add these 2 things, what we call as the simplified PESI criteria. Then you have to assess the RV function using imaging and biomarkers. Patient, those who are high risk, they are the hemodynamically unstable patient. They are the patients who are going to die in the hospital. Then there are intermediate high groups, simplified PESI more than 1, and both imaging and biomarkers are positive. What are the low group, intermediate low group? Simplified PESI is more than 1 and either of them is positive. And the lowest risk group, simplified PESI may be 0 or 1, but the RV function, imaging and biomarker both are negative. So in this way, we approach the diagnosis of pulmonary embolism. In the next class, we will discuss how to treat these patients. Thank you very much.